So thank you very much, everyone, for joining this morning's St. Michael's virtual echo rounds. I'm going to talk about the echocardiographic assessment of cardiac amyloid, one of the hotter topics these days in the field of echo. And certainly, we're very fortunate at our hospital that Dr. Gordon Moe and Haven Shura, it's really taken on to form the cardiac amyloid clinic. And it's really fantastic. Now we have a home to help patients with this rather rare conditions and often misdiagnosed. So I have nothing to declare in terms of disclosure, apart from some um, speaking opportunities. The objective today is to talk about what is amyloid and the cardiac involvement. We'll talk about the classic echo features of cardiac amyloid and describe the novel and emerging echo features that we're going to talk about, and also some of the more novel ways of detecting cardiac amyloid, including ways that we can do with artificial intelligence. So what is amyloid? This is something that we all learn from medical school. All of us learn that. But over the last 20, 30 years, it started from a disease that we seldom see, and once we see it, it's like a death sentence because there's not much treatment. To really, in the last 5 or 7 years, that we really have transformed how we deal with this problem. We recognize that we are underdiagnosing this condition. It's more frequent than what we normally would think about. And also, there are now specific treatment if we can identify early. So in this particular session, we're going to talk about all that. On the left side of the panel, we can see a very simplified way of looking at how amyloid occurs. There are different forms which I'm going to talk about. There's a plasma cell dyscrasia, as well as a malfunction of the folding of the polymers that leads to amyloid fibrils in our body. So there are two different types, which we're going to talk more about. The diagram really just talked about the liver version, which is the TTR version. And on the right side of the panel, we can see that amyloid is a disease that can affect many parts of the our organ throughout our body. One of the common things that we can see is orthostatic hypertension, GI dysmotility, erectile dysfunction, which is very nebulous when people present fatigue, anorexia, weight loss, etc. And then later on, they would describe something more specific, macroglossia, which is a big, thick tongue with infiltration, hemorrhage and cerebral hemorrhage and stroke dementia. In very extreme form, they can have periorbital purpura, which is like purple around the eyes, which doesn't we don't see that often in our clinical practice because we tend to discover them hopefully early than later. The big thing that we talk about is heart failure, usually with preserved ejection fraction in early phase, and also low flow, low gradient aortic stenosis, conduction abnormalities, syncope, hypotension, and chest pain. As far as the kidney is concerned, you can have proteinuria, nephrotic syndrome, renal failure, and from a neurological standpoint, you can have a carpal tunnel syndrome, and further down the feet, you can have painful paresthesia, and also with the heart failure piece, you can have ankle edema as well. So again, you can see that it's something that affects a lot of different parts of our body. So more specifically, the cardiac amyloid, we have a very nice paper that's actually from the Canadian Cardiovascular Society that one of our colleagues, Noel Find, as well as Margot Davis, put together with many different colleagues across the country to talk about this particular condition. So cardiac amyloid is defined by deposition of these misfolded precursor protein that I told you about as fibrillary amyloid deposits in cardiac tissues, resulting in infiltrative cardiomyopathy with associated heart failure symptoms. There are two primary subtypes. We used to learn a lot more different types, but now it's make it easy for us to simplify it. Two primary subtypes of systemic amyloidosis causing cardiac involvement. One of the main one is called AL, which is amyloid light chain or immunoglobulin light chain. It's actually a plasma cell dyscrasia, meaning that the bone marrow actually create plasma cells, and then it then generate a lot of these fibrillary amyloid deposits. The second type is more from the liver, which is the ATTR, which is coming from the liver, is a type of transferrin. There are two main types with the ATTR, and the new drugs are more primarily targeting that. It's the hereditary type, which is the HATTR, and it's due to a gene mutation of the ATTR protein. And then there's another type called wild type, which is WT. Is more age-related. As we get older in the 70s and 80s, then people are more likely to have it. So just looking over the general demographics, the AL type, usually people started around age 60, slightly more male, no ethnic preponderance, and it's about 10 per million, not that common. The ATTR version on the hereditary type, it really depends on the genotype. It's actually also dependent on the ethnic background, depending on whether you are like European, North Americans, or Japanese, for example. And the prevalence is actually variable depending on genotype. While the wild type is something that we also see quite commonly these days, is patients are a lot older and more male, and the preference actually increases with age. Again, we're still working on how often this occurs. There are different ways that people present. There's something that's across all the different types. There's orthostatic hypertension, gastroparesis, sexual dysfunction, sweating abnormalities, which was very generic. And some patients will present like with having hypertension, and then all of a sudden they realize that they don't need their blood pressure medication. They start feeling dizzy, etc. Those are the things to look out for. They can have muscle weakness, etc. And also they can have nausea, constipation, abdominal bloating. Again, if you can imagine, these are very common complaints. So initially, when people complain to the family doctor, it may not be that easily picked up initially. But on the AL side, you're more likely to have renal insufficiency, nephrotic syndrome, bleeding and easy bruising, etc. And with the HTTR type, they're more likely to have carpal tunnel syndrome, elevated liver enzymes, and also vitreous opacities. While wild type, they're more likely to have spinal stenosis and bicep tendon rupture. So those are the things that we watch out for on the ATTR type. If you have renal failure, they tend to be slightly milder. So these are some of the clinical ways to find out about them. The other thing about cardiac amyloid is that it's very protein, meaning that is like it presents in a very variable way. I actually pull out a picture of Proteus, which is a Greek god, which is like multiple forms. In autopsy studies, myocardial ATTR deposits have been identified up to 25% of individuals older than age 60. So again, 1 out of 4 older than 80 years old who died could have some degree of ATTR deposits in the heart. The non-invasive methods have identified ATTR in about 13% with heart failure with preserved ejection fraction, HFrEF. And again, this is something that I learned from Dr. Mo, that if someone who have HFrEF with heart failure, and they can have up to 1 out of 8 that you can actually have ATTR. So again, I do applaud and think that Dr. Mo is great in terms of identifying these patients and get them through the diagnosis process and doing the paraphosphate scan and specifically looking out for these type of patients. 16% of the patients who undergo TAVI or TEVR for severe AS also have been identified to have amyloid as well. So again, that's sort of pertaining to our structural clinic, whether it's worthwhile to screen all of them or screen some of our patients with low gradient, because, again, close to 1 out of 8 or 1 out of 7 patients would actually have amyloid. 5% of patients with presumed hypertrophic cardiomyopathy would have the amyloid as well. So again, when we have patients coming through our echo lab, if they have thickened wall, it actually backs the discussion that we should be doing the GLS on a more regular basis for people who have actually thickened wall, because you can actually pick these things up. So why are we actually trying to pick these things up? Because now timely diagnosis is important in this condition. Overall prognosis is rather poor if left untreated. However, effective therapies are now available to halt the disease progression and improve the survival. And earlier disease is more treatable than above. So again, echo is one of the first line of making these diagnoses. So it's important that we have a heightened alert to actually pick these things up. So again, going the extra step of when you see a thickened ward, we should do more GLS and also look out for amyloid presence. Clinically, when we suspect cardiac amyloid, is when there's a new onset of heart failure with one or more of the following findings. Unexplained increase in LV wall thickness. For example, someone doesn't really have hypertension and then the wall thickness is 12 or above, then it starts making you thinking. Low flow, low gradient aortic stenosis with preserved LV ejection fraction, especially in older age group, more than 60. Patients presenting with carpal tunnel syndrome and established AL or ATTR in non-cardiac organ involvement, and especially with renal AL amyloidosis, with patients presenting with nephrotic syndrome, and also patients with peripheral sensory motor neuropathy and or dysautonomia. So again, those are all the clinical symptoms that we would look out for this kind of situation. So more specifically, now let's go to the echo assessment of cardiac amyloidosis. There's a very nice paper that was actually presented by Dr. Sharif Nagwa, who is our god of diastolic dysfunction. And from Methodist Hospital in Texas, they wrote this very nice summary article on echo assessment. It was published in 2021 in Heart Failure Review. So I'm going to go through like the way that they put it all together is a very nice and organized fashion. And before we go there, we're going to talk about why we have these echo finding with amyloidosis. So amyloid protein deposition surrounds, compress, and ultimately replace cardiomyocytes. So this infiltration causes the thickening and stiffening of the cardiac chamber and make the left ventricle much less flexible, so with impaired LV relaxation and later on contractility, as well as electrical conduction abnormalities as well. The circulating light chains in the AL cardiac amyloid that have direct cytotoxic effects. Amyloid deposition occurs throughout the heart, including PET muscles, cardiac valves, pericardium, and perivascular tissues. Atrial infiltration also occurs with amyloid, resulting in atrial mechanical dysfunction and predisposition for intracardiac thrombosis and also systemic embolism despite sinus rhythm. So again, when patients with AFib, we're much more alert in terms of anticoagulating patients with amyloid because they're more likely to form clots. And also there are specific atrial function assessment as well that we're going to talk about. So there are three areas that we're going to talk about in terms of echo assessment of cardiac amyloid. There's morphological features, there's diastolic dysfunction, and also systolic function, and also some other novel parameters. So let's look at the morphological features first. These are things that we learned in medical school as well as early part in our echo training. So we specifically look for myocardial wall thickness. So when walls are 12 or more, in the absence of other plausible cause of LVH, abnormal LV relative wall thickness more than 0.42, like those type of concentric remodeling type of thing, and RV free wall more than 5 millimeters. So infiltration will occur in the RV free wall as well, especially in the subcostal view. The echogenic appearance of myocardium can also be useful, and they often have this starry night pattern of it with the granular sparkling appearance of myocardium. But again, because we start using harmonic imaging about 18 or 20 years ago, it makes it less specific. But on the other hand, you can actually turn off the harmonic imaging to actually take pictures of it, and then you can actually use it as one of the diagnostic methods still. When there's increased LV mass disproportionate to QRS voltage, that's another feature. And later on, I'll show you an artificial intelligence paper that take advantage of this concept. So often these are patients with thickened LV wall, but when you look at the ECG, because of the infiltration of the myocardium, the voltage itself on the ECG actually decreased or not increased. The LV cavity is usually normal or small. The atrium is often enlarged because of diastolic dysfunction with elevated filling pressures. the interatrial septum and the valves are often thickened. One of the other features that is very interesting is that, like, how we talk about apical tenting, and because of the infiltration of the mitral valve, you can see mitral valve stiffening. So you actually can have apical tenting with normal left ventricular size. So that's another interesting feature to look for, because the mitral valve actually gets stiffened and it doesn't go back to the annulus. You often have pleural and pericardial effusion as well, but they are not specific in association with cardiac amyloid. So this is just a 2D image that showed presence of pericardial effusion, pleural effusion, large pleural effusion here. The walls are actually quite thickened at this sparkling appearance. The leaflets are thickened, both mitral and aortic, and left atrium is enlarged. This is a apical four-chamber view. You can see the ventricles are thickened. You can see the mitral valves actually apically tented and also thickened as well. And also the interatrial septum is thickened, and also the left atrium is enlarged as well, with the 2D features that we're looking for in cardiac amyloid. In the subcostal view, you can see the similar features with left ventricular hypertrophy, left atrium enlargement, interatrial septum thickening. The mitral and aortic valve leaflets are thickened, and also there's a small amount of pericardial effusion as well. More importantly, in the subcostal view, you can see the RV wall actually thicker, more than 5 mm during diastole. That's another sign to look out for as well. The other morphological features that we're trying to look for to distinguish this when we see wall thickening, how do you distinguish from cardiac amyloid versus other disease pattern? So for example, something that we talk about is cardiac amyloid tends to infiltrate everywhere. So they tend to be very diffuse. The wall thickening tends to be symmetrical. However, there are papers that actually described asymmetric left ventricular hypertrophy presence when patients have cardiac amyloid. So when you see, thickened heart, again, the message is we should really do more GLS to try to look for the specific pattern that we're going to describe with the cherry on the top, for example. And the other thing is the granular sparkling echotexture of myocardium. So we can see, the similar patterns among patients with chronic kidney disease or other infiltrative cardiomyopathies. Again, harmonic imaging can also mimic this appearance. So again, the message is for sonographers: if you do see thickened wall and you think that's possibility of amyloid, turn off the harmonics and just write in the text fundamental imaging. Then you can actually have something to compare with. So add another tool for us to try to figure out whether these patients have amyloid. And again, having the presence of the ECG can be helpful. On our ECG machine, it's hard because we can turn up and down the amplitude, so it may not be that helpful. But on the other hand, if you have access to a 12-lead ECG where you see actually very low voltages, despite the ventricle is quite thick, and that can be very helpful for making the diagnosis. The other thing that is important is the presence of intracardiac thrombosis and embolism predisposition among patients with cardiac amyloid. Because of endothelial dysfunction, hypercoagulability, and stasis, in a study of 116 autopsy or explanted cases of cardiac amyloid, they often find intracardiac thrombosis up to about 1/3 of the hearts. And the other thing is cardiac amyloid is associated with aortic stenosis, and a prospective study in multi-center, there are 408 patients referred for TAVR, and about 12%, as I mentioned, were found to have cardiac amyloidosis, especially among the patients with paradoxical, low flow, low gradient, severe aortic stenosis. The other focus that we can talk about is actually assessment of diastolic function. I pull out a couple of papers which are very important in the history of echocardiography, because amyloid is one of the areas where diastolic function assessment was very important, described initially, and for not only the description of a variable presentation pattern from mildly impaired to moderately impaired to restrictive type of pattern, initially described through the ENA pattern as well as the deceleration time. But more importantly, it was actually done by Dr. Alan Klein, who is actually Canadian, who went on to Mayo to did a lot of work and put put this on the map. So we should be proud of our Canadian heritage. The other paper that Dr. Klein, after describing the variable presence of diastolic dysfunction, was actually using the deceleration time as well as ENA pattern to actually come up with the prognosis. Again, this is one of the first paper in echocardiography that actually use echo for coming up with the prognostic significance. So historically very important, and it's done by a Canadian. So what he did is actually he took about 63 consecutive patients with biopsy-proven systemic amyloid, and he looked at the deceleration time initially, and then you find that if the patients who have very small deceleration time, less than 150 milliseconds, the prognosis is much worse than the other group of patients who have deceleration time that is longer. So again, deceleration time is a surrogate for left atrial pressure. So again, the more diastolic dysfunction you have, the more severe it is, the higher the left atrial pressure, your prognosis is worse when you have amyloid. You further subdivide among these group of patients with a low deceleration time, and then start looking at the E to A ratio, and you can see patients with deceleration time less than 150 and also E to A more than 2.1. So these are the patients with the highest left atrial pressure as predicted. Their outcome is going to be a lot worse than patients who have a EA that is slightly less than 2.1. And obviously in that other subgroup of patients with deceleration time of more than 150 and also the EA is less than 2.1, they have the best prognosis. And while but there's only one patient, but then among all the patients with deceleration time more than 150 and less than EA less than 2.1, the prognosis is slightly worse, but not as bad as people with a short deceleration time and high EA. Okay, so again, this is a historically important because of the ability for echo to actually predict prognosis, like fortune telling in using echo, one of the first papers. The other paper that was interesting was actually using just LA dimension. This is done by a group from Dr. Duminel as well as Dr. Pibero from Laval, where Dr. Jeremy Ong trained originally. And they specifically look for left atrial size is the AP dimension among patients with systemic amyloid. And they find out that when they use LA size adjusted for body surface area and with the LA dimension index among patients who have systemic amyloid versus cardiac amyloid, and each of them will show that if you have a larger left atrial size, which is by this turquoise line, the prognosis is much worse than patients with fairly normal left atrial dimension. Again, at the time of this publication of the paper in 2011, at that point we thought, and it's still true, that left atrial size is very much a surrogate for left atrial function as well as diastolic dysfunction. So sort of like the HbA1c of the diastolic dysfunction. So aggregates everything as a simple parameters, and you can actually use it for prognosis. So again, another very important paper in 2011. So moving along, very rapidly into 2017, when now we have all these tools, and we are now able to measure LA strain in addition to all these other systolic strain and GLS that we do. So here with the newer software, we can actually look at the different LA function phase, including its systole, which is called the reservoir function phase, the diastole, which has two parts, the conduit, as well as active phase. Among patients with or without cardiac amyloid, they all have, patients with cardiac amyloid compared with normal individuals, they have lower longitudinal strain and lower LSR, as well as lower early ESR both peak and early, and also lower late LSR. So these are the systolic strain that you look at, and all among patients, your left atrial function because of the infiltration is much worse in all different functions. Further on, this particular paper sort of look at all the different functions, and then they look at, in combination, the size of the left atrium as well. So by combining the function and also the LA size, so the bottom line is, if you have cardiac amyloid, if your different function is lower with larger LA size, your function is going to be a lot worse, and the prognosis is going to be worse when you have that. So in summary, in LV diastolic function, the spectrum of diastolic dysfunction will progress from impaired relaxation, grade 1, to pseudonormal, to restrictive filling pattern with increasing severity of amyloid infiltration. That was one of the first papers that Dr. Klein did in the early part of the echo history. And then also there's another thing that I haven't talked about, is that the tissue Doppler on the mitral annulus, both the septum and the lateral, will both be decreased as well. And the LV diastolic function will also be impaired and associated initially with impaired relaxation pattern on the right side, and then in advanced disease is associated with restricted filling pattern on the right side as well. There's going to be impaired left atrial strain, and due to adverse loading condition and also atrial amyloid infiltration. And patient will also present with pulmonary arterial hypertension as well. So those are all the findings that we should look out for in diastolic function part. As far as the systolic function part, typically patients with cardiac amyloid, initially the ejection fraction is preserved until later stage of the disease. Then, like, we call it more like the burnout phase, and then the ejection fraction will get worse and worse with the infiltration over time. The stroke volume will also be decreased because of the infiltration. The LV volume size is going to be decreased, and also diastolic function dysfunction is present. So the LV stroke volume overall, despite the preserved ejection fraction, is going to be decreased. The ratio of the LV stroke volume to LV mass is going to be decreased as well. There's a concept called myocardial contraction fraction that is in the literature, especially on the research side. The LV global longitudinal strain is going to be decreased. And also there's a regional pattern that I'm going to talk more about. It's called cherry on the top, which is quite well known now. Is preserved apical longitudinal strain with impaired mid to basal longitudinal strain. And there's also a concept called SAB, which is the ratio of septum apical to basal segment more than 2.1. That means the apex is still contracting, but the base to mid is not contracting. And this ratio is more than like 2.1 to 1, then it's considered to be abnormal. And the LV systolic dysfunction can also occur as well because of the infiltration. So your TAPC is going to be decreased more than, less than 17, and also your S prime is going to be decreased less than 9.5 centimeter per second. This is the famous paper that's actually one of our colleagues in Toronto, Dinesh, did together with Dr. Marwick and also Dr. Thomas and also Dr. Planer when he was in Cleveland Clinic. And that was published in 2012. And what they did is they described patients among amyloid. These are typically A1 to A4 pattern, which is there's apical strain is actually preserved, while the mid to base is actually affected. This is in comparison with other pattern. B1 and B2 is actually asymmetric hypertrophic cardiomyopathy, where the septum strain is actually affected but nothing else. And C1 and C2 is actually patients with aortic stenosis, where the strains can be affected globally and in a very patchy fashion. So that's leading to the very famous cherry on the top description of the GLS strain pattern. Again, further on in the paper, they look at, basically among patients with cardiac amyloid, there's a progressive decrease decrease in this way from, apex is preserved while mid to base is actually more affected. And typically what we're looking for is a ratio of 2.1 to 1 from apical to base in terms of the GLS to look for the dysfunction. Now, we just look at basically all the different parameters separately just now in morphological features, some of the diastolic function assessment, and also the systolic assessment. And well, while you can use separate score separately, but people have looked at using something called multi-parametric echo score for diagnosis of cardiac amyloid. This is one of the papers that was published in JACC in 2020. And what they did is they basically separated the patients that they have in terms of cardiac amyloid. So they created one particular score set for patients with AL type of amyloid or amyloid-like chain, and also patients with cardiac amyloid, which particularly with increased wall thickness. That's what IWT stands for. They come up with two different models, and this is relative wall thickness, E over E prime that we're familiar with, TAPSE on the right side, and longitudinal strain. So it's a pattern that we have, and they have set up specific cutoff score and different points. In the IWT version of amyloid, that is not AL, they added in addition the septal to apical systolic apex to base. So that's SAB, more than 2.9 as a cutoff, and they ascribe certain points to each of these things. So again, these four parameters are the same, but in increased wall thickness, they added the systolic apex to base ratio in addition to that to improve the accuracy of the modeling. So again, what they did is they did cardiac MRI on all these patients, and they find out that the higher score that you have in both AL as well as the increased wall thickness, the higher score in this multi-parametric predict the higher volumes of amyloid that is in your heart, as represented by the extracellular volume that they did in the MRI. So again, the more of these things that being abnormal, the more likely that you have a worse form of amyloid. What is still interesting to know is that by treatment, whether these scores will regress and whether that could actually predict the volume of amyloid decrease. So that's something that that will be a nice next step in terms of research for this. A very quick case. That's what we do on a day-to-day basis. 68-year-old male presented to a clinic or to our echo lab with shortness of breath and neck swelling for 3 months. Anti-BNP is elevated, TROP is elevated. So they use anti-BNP and TROP as one way of actually prognosticating patients as well. And chest X-ray in this case showed pulmonary edema. So again, this is someone that's parasternal long axis. You can see the walls are very thickened. It's very sparkly with the harmonic imaging in this case. The leaflets are thickened. The mitral valve is somewhat tented because of the stiffening of the mitral valves and infiltration. And this aortic valve is also thickened as well. RV is actually decreased in function as well. And there's a slight, very slight pericardial effusion that you can see in the posterior wall. And again, this is a very beefy ventricle. And this is the apical four-chamber view. You can see the ventricle is infiltrated, the leaflets are infiltrated, both on the tricuspid and the mitral side, and also the interatrial septum is also thickened as well, and left atrium is enlarged. So again, all the okay. So, and also with the resultant of the stiffening of the mitral leaflet, you can get variable degree of mitral insufficiency as well as tricuspid insufficiency as well. In the subcostal view, you can see all the features that I just talked about. In addition, there's a small amount of pericardial effusion, and also the right ventricular free wall is actually increasing thickness as well. So this is a very typical one that you would be very suspicious of cardiac amyloid. But I mean, the goal is really to look out for patients that are not as typical. In addition, these patients have the mitral TDI. So you can see the velocity both in the septal side as well as the lateral side is decreased, about 6 or 7. So again, 5 or 6 in this case. So again, these are features that we look for when both the septal and lateral, the E prime is decreased. Then we have to think about amyloid as well. To further do the GLS or global longitudinal strain. So again, this particular patient, this is actually from this patient, and you can see the apex strain is actually preserved, while the mid and the base are all significantly impaired. This is thought to be related to differential infiltration of cardiac amyloid, where the apex is pretty much spared, relatively speaking. So again, resulting in the global GLS being down, but the apex actually still being quite preserved. Okay, so last but not least, coming to the end. So the different ways that are novel in terms of trying to identify these patients with cardiac amyloid, since they are so protein. And this is a paper that was published in Nature Communications, looking at using artificial intelligence, machine learning model for identifying patients with wild type TTR. And in this case, they used a electronic health record. Then they use machine learning, and one of the methods is called random forest method, to actually look at all the variables that are the top features that can help to identify both the phenotypes and the phenotype combinations as well, and then leading to different AUC curve to try to come up with the model, and they will use external cases to actually for validation and come up with the clinical application. Again, this is a kind of map that they will generate with the cardiac features and non-cardiac features that is actually in the EMR. And you can see that many of them are like, external to echo. So they have like abnormal ECG, bundle branch block, and heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, so on and so forth. So it's a grab bag of all the features, and also they have non-cardiac features, like including things that we talk about, for example, poor effusion and carpal tunnel, things like that, and presence of multiple myeloma, etc. And so using all these as sort of clinical features to actually look for amyloid, and with that they're able to come up with quite good identification with patients with wild-type ATTR. There's another paper that is also published in Nature Communication. Is a study that was actually conducted both in US and Japan, and they basically look for the features that I just talked about with the ECG features of low voltages, and then also patients with thickened ventricle. So what they did is within the Brigham and the Mass General and UCSF, they come up with the ECGs, and they come up with a model that try to predict cases versus control, and they're able to quite reliable do that. And then they added on top new echo features. They train the model, and then they apply to another set that is actually done in the echo with a thickened wall, and they are able to substantially increase by using these two-step method of increasing the positive predictive value of identifying patients from 33% to about 74 to 77%. So again, using very simple key features that they can actually screen patients with a reasonably good outcome. There's also different method now using natural language processing to go through your EMR by searching specific features in your medical record, like HEPREV, low flow, low gradient aortic stenosis, all these other clinical features. You can actually try to identify the patients as well. In terms of echocardiographic findings, there are limitations, as you all know. So traditional echo diagnostic criteria have lower sensitivity for cardiac amyloid because not everyone is as fragrant as the one that I just showed you, and many of them are mimickers, and they could present at a very early stage. So again, having a very high index of suspicion is very important, especially for all the clinical features that we talked about. HEPREV, for example, low flow, low gradient AS is also another example that we should really think about amyloid. Echo also cannot reliably differentiate between AL and ATTR subtypes, so we need additional features. Cardiac MRI, because of different patterns of infiltration, they could try to tell. And obviously having genetic testing is also very important. Nuclear scan with the pyrophosphate scan is also very important. Again, echo is usually the first line because most people would have that, ECG and echo, and then you need further tests to actually figure these things out. And having a high index of suspicion is very important. Again, at present, the role of echo or other imaging modality in assessing response to treatment of cardiac amyloid is still not so well established. So again, this is the area that we need to focus on looking for. So in summary, cardiac amyloid remains an underdiagnosed cause of rapidly progressing heart failure. The evaluation of cardiac amyloid entails a multimodality imaging approach encompassing echo, MRI, and also nuclear imaging. Echo widespread availability, accessibility, and low cost makes it the first non-invasive imaging modality used when investigating patients with cardiac amyloid or suspicions of it. Although not being highly sensitive nor specific to confirm the diagnosis, echo provides critical information regarding disease status, cardiac function, and follow-up in the setting of good image quality, and among us as clinicians, high index of suspicion. The combination of echo and MRI provides a valuable anatomical functional cardiac assessment in an effort to increase suspicion and maximize diagnostic accuracy, and obviously nuclear as well, because that's one way that we can screen patients, and we do that at St. Michael's Hospital, thanks to Dr. Mo and his team. And echo is the first line test to identify non-specific signs such as ventricular wall thickening, restrictive filling pattern, and CMR enables high-resolution structure assessment as well as qualitative and quantitative measurements of the degree of amyloid infiltration. So with that in mind, I want to thank you for all your attention to this presentation. I hope all of you get the message that we have to keep a very high index of suspicion. Not every case is as obvious as the one I show you. We have to, like whenever we see the thick wall, we really should think about doing the GLS. Anything that is more than 12, maybe we should look at adding that to our protocol in the cardiac sonography scanning. And also any patients with low flow, low gradient AS, we should have a high index suspicions of amyloid as well. This is a website that was actually prepared by Pfizer. It's actually quite useful for patients as well as clinicians to learn about this condition, so I just leave it at that. So it's now 8:49, so let's see if there's any questions.
Gordon Mo here. Sorry, I'm attending the TXC clinic, so I didn't catch everything. But I'm intrigued by your presentation of left atrial function. Are we doing it routinely in the St. Mike to look at reservoir and conduit function?
Yeah, great question. It is an area of active research interest. I think your project together with Vassner and Geraldine, they are looking at that. The atrial function assessment is not necessarily built into our machine. So right now it's not that easy to do them both with the echo machine or with the echo pack that we use right now. We have to actually download to a research system to be able to do that offline. So again, I think as time goes by, this area will be an active area of research, and we'll be doing it more often. Like similar to what we did before. Like we used to do PISA very infrequently. Now pretty much we do PISA whenever we have moderate to severe MR or TR. So I think this is one area that will become more and more popular, but we need the software to catch up with us to make it easier for us to do.
Thank you.
Thank you for joining our meeting, and thanks for all the great work that you do in this particular category for us.
Thank you.
Okay, so any other questions? So without further ado, I want to thank all of you for joining this session. Thanks for your support for the virtual Echo Round. And if you have friends and colleagues who are interested in joining us, please subscribe, and you'll get a weekly reminder of the sessions we're going to present. Also, you would have access to our online library as well. So for different topics, it's great for especially great for people are joining our field, because we have like a very wholesome collection of different echo topics. So I want to wish you a wonderful weekend to all, and a wonderful summer. And we'll start, I think we'll start definitely in July and a new academic year, and we'll see what we have next week. So thank you. Have a wonderful day, and thank you.